While bariatric surgery can deliver strong results, there are risks and complications associated with any surgery. Complication rates are generally low in bariatric surgery.
The best safety data about the risks of bariatric surgery come from the LABS consortium, a very large longitudinal study of thousands of patients studied for a long time. And in a New England Journal paper, they published the death rate, to start with, from, let's say, a laparoscopic gastric bypass, the most commonly performed operation in bariatrics in this country and by many considered the gold standard. The chance of dying from any cause within 30 days of that operation is 0.2%. To put that in perspective, the chance of dying from a gallbladder removal is 0.3%, and nobody would consider cholecystectomy to be a risky surgery. In fact, 0.2% is considered a low mortality rate for just about any surgery, far less morbid and mortal than many things we often do, like cardiac bypasses or even hip replacements. There's about a 5% chance of having a major morbidity, like having to have another operation or being intubated or staying in the hospital for a long time. That's a more meaningful number. But you have to balance that against the risks of not undergoing surgery if you're obese and sick enough to qualify for it. And there are now many studies that compare the long-term all-cause mortality among patients obese enough to qualify for surgery by current standards, who choose to have it versus choose not to. And they all report that the overall all-cause mortality is lower among the surgical patients.
Patients need to understand the potential risks of undergoing any surgical procedure. Similar to any other surgery, patients can experience pain, infection, and bleeding. Common bariatric surgery risks include anastomotic breakdowns, where the unions between the pouch and the small bowel, or the small bowel attaching to itself, break down. The equipment used today has greatly improved these surgical unions. Anytime you rearrange the GI tract, there is some risk that these anastomoses will not heal adequately, so the risk of anastomotic breakdown is small but real. After the anatomy has been rerouted in this manner, sometimes ulcers can occur. Additionally, some patients experience a phenomenon referred to as dumping, where if patients eat too many sugary type foods or carbohydrates, they can get an effect where they become very fatigued and have headaches and need to just lay down and recover from that amount of sugar being immediately delivered to the small bowel. With vertical sleeve gastrectomy, patients can experience symptoms of heartburn and what we call dysphagia, or difficulty swallowing in the first few days or weeks after surgery. They may also experience a leak from the staple lines. Strictures, or narrowing of the stomach, where the extra stomach has been removed, can also occur. They usually don't manifest themselves until weeks or months after the surgery. Anytime a patient has undergone significant and rapid weight loss, they can develop gallstones, and they may require a second procedure to remove the gallbladder.